Aspiration pneumonia. Aspiration pneumonia is a disease which is caused by impaired swallowing and impaired cough reflex, and there are a variety of other causes. So the patient cannot form bolus, and they usually aspirate, and frequently occurs in ITU settings in the patient who have a stroke or patient who have dementia. It is common in older people and caused by oropharyngeal dysphagia, cerebrovascular, degenerative, and neurological diseases, oropharyngeal bacterial colonization, and poor oral health, and associated with aging, multimorbidity, undernutrition, reduced functional and cognitive reserve, non-specific presentation of disease, and we need to prevent and manage if it happens. Incidence of pneumonia increases with aging and frailty of the patient. Morbidity and mortality from pneumonia increases with aging. Aspiration is the misdirection of oropharyngeal or gastric content into the larynx and lower respiratory tract. Aspiration pneumonia develops after aspiration of bacterial colonized oropharyngeal contents. Aspiration of bacteria from oropharynx is the primary pathway by which bacteria gain entrance to the lung. So in community-acquired pneumonia, the diagnosis of bacterial cause of community-acquired pneumonia is made in less than 50%. Particular problem is a frail elderly patient, often unable to produce adequate sputum specimens. Higher prevalence of the gram-negative pathogens and Staph aureus in elderly patient with CPAP, presumably due to oropharyngeal colonization with subsequent aspiration. Streptococcus pneumonia remains the single most common implicated pathogen in elderly patients. Unclear if the patient with dysphagia are at risk of acquiring pneumococcal pneumonia. Risk factors of pneumonia: silent aspiration in 70% of the patient with community-acquired pneumonia compared to 10% in control. Resident of long-term care facilities, difficulty in swallowing food, medication, witness aspiration, sedative medication. The preserved swallowing or cough reflex are important defenses against the oropharyngeal aspiration. Impaired swallowing cough increases the risk of aspiration pneumonia. Approximately half of all the healthy adults aspirate small amounts of oropharyngeal secretions during sleep. Most have no sequelae. The low bacterial burden of the normal pharyngeal secretions, coughing, active ciliary transport, normal humoral and cellular immunity. So increase in RCVF over the large scale distributed in neural network. Right and left inferior precentral gyrus, right anterior insula, left cerebellum, putamen, thalamus, and several other cortical areas. Nosocomial pneumonia is common in acute stroke patients. And dysphagia after the stroke, patient have difficulty and inability to swallow. 50% of acute stroke patients have clinical dysphagia. Most 80% with resolve in first 7 to 10 days, associated with big strokes, aphasia, increased risk of pneumonia. Poor oral health or oropharyngeal bacteria colonization after stroke. Can't do oral hygiene, reduced conscious level, impaired hand and arm function. Can't ask for oral hygiene, communication barriers, dysphagia, delirium, dementia, increased oral vulnerability, dysphagia, xerostomia, nil by mouth, drugs, and nutritional supplements. Poor oral health in older people is often associated with other problems. Poor oral health, chronic physical disability, cognitive decline, and dementia, sensory impairment, hearing, vision, acute illness. Mechanism: common risk factors: cigarette, alcohol, socioeconomic status, and low education. Two-way relationship: poor oral health, systemic illness, poor oral health. Swallowing assessment and investigation after stroke is the SALT assessment, swallowing and speech and language assessment. Routine assessment: look into the mouth, no impaired consciousness, water swallow test, bedside swallow assessment, selected patient, nase endoscopy, modified barium swallow, video fluoroscopy can be done. So there is reduced homeostatic reserve with aging, multiple diseases, frailty, and undernutrition, iatrogenesis, adverse drug reaction, non-specific presentation of the disease, and multiple problems requiring complex solution. So FVC and FEV1 also decreases with aging. Older people swallow more slowly, laryngeal vestibule closure is delayed, and maximum hyalolaryngeal excursion is delayed. Upper esophageal sphincter opening is delayed. Oral bolus transport into the time is prolonged. Safety of the oropharyngeal swallowing is not compromised. No increase in frequency of aspiration in radiographic studies that compare to older to younger adults, however reduced physiological reserve. Cough reflex is a respiratory defense. No apparent effect on healthy aging on the cough reflex. The cough threshold concentration for inhaled citric acid is 360 mg per ml in survival of aspiration pneumonia. Non-specific presentation of the disease: intellectual impairment and dementia, immobility, instability, falls, incontinence, and loss of swallowing. Management strategies including assistance with the regular oral hygiene, screening, nail by mouth postural intervention, hand feeding, small amount, frequently modified diet, thickened fluid, and food supplements. Aspiration is the main cause of pneumonia and later life oropharyngeal dysphagia plus bacterial colonization, frailty, cognitive impairment, and multimorbidity. Non-specific presentation and potential for prevention and multimodal and multidisciplinary strategies are needed. Thank you.